Hi guys, good morning, or good afternoon, or good night, whatever you prefer. Okay. I want you to listen to all these tapes before you go on and you take other tests and so forth. I think the first one was an hour and a half, but we're going to kind of lower this one. In time-wise, we mentioned something last time, primarily concerning the nervous system, and I think all I did, and I apologize, is to kind of hit it and move over. I didn't really explain it a lot. And so your nervous system has two primary areas under it. One is called central nervous system. And your central nervous system is your brain that primarily controls everything, your thought, your intellect, your body temperature, your skeletal muscle movement, long and short-term memory. I mean, you pick up a book and say, hey, this is mine. That's cerebral. That's brain. And coming off the brain is your spinal cord. And I look at the spinal cord kind of like a major extension cord, carrying information away from the brain and back towards the brain. So your brain and your spinal cord are the main components, the main areas, the two subdivisions of your nervous system under central nervous system. Okay, also you're going to see things like if we talk about this is a CNS stimulant, drinking a lot of coffee, a lot of 5-hour energy, okay, that's central nervous system. If you see something on a stimulant, that kind of revs it up. If you see something on a depressant, like narcotics, okay, that will depress your brain and spinal cord. And you got to think once again, all of your vital signs, your heart rate, your respiratory rate, your body temperature, your respiratory system is under CNS, your brain and your spinal cord. That's all controlled by that. The other side of the picture, besides CNS, remember this is all under nervous system, is your PNS, or your peripheral nervous system. Well, the peripheral nervous system is basically 31 pairs, 64 in all, of spinal nerves. So you've got nerves exiting your spinal cord. Because what? Your brain doesn't go out to your hand or your foot or your facial muscles. Okay? So you have these nerves off of the spinal cord that do. And then off the base of the brain, you have 24 pairs of cranial nerves. So 12 pairs of cranial nerves, 24 in all. And your cranial nerves basically take your brain, because where is the brain? It's behind bone, right? Well, your brain doesn't go out your face or your heart or your stomach. So a lot of these, for instance, your eyes, okay? The optic nerve, which is one of the 12 pairs of cranial nerves, takes your eyes and kind of plugs it into the brain. So the way I look at this is your peripheral nervous system is like plug and play. It's like plugging in your brain and your spinal cord to the rest of the body. So 12 pairs of cranial nerves and 31 pairs of spinal nerves is plugging in the brain and the spinal cord to the rest of the body. Now, off of the central nervous system, okay, or off of your peripheral nervous system again, is two subdivisions. So you have your central nervous system, your brain and your spinal cord, and your peripheral nervous system. 12 pairs of cranial nerves, 31 pairs of spinal nerves, which again is like wires, nerves, attaching the brain and the spinal cord to the rest of the body. Now, the other thing that you're going to come out here is the peripheral nervous system plugs in to two subdivisions. It plugs into the somatic nervous system and it plugs into the autonomic nervous system. Excuse me for a second while I get a little, here's my drink of choice. It actually has some Bud Light in it for when we go 2 more hours into the evening because once again, it's got to be 5 o'clock somewhere. Okay, so The somatic nervous system primarily controls skeletal muscle movement. If you see the word soma, that's the body as a whole. Somatic nervous system is under your conscious control. You move your hand, you move your legs, you move your arms, okay? That is somatic nervous system. And you can start it, right, and stop it at will. Okay, so the somatic nervous system is under conscious control, and it's basically controlling skeletal muscle movement. And then you hit another division of the peripheral nervous system, okay? And that is, you hit autonomic, sometimes called ANS. So the autonomic nervous system is not under your conscious control. It's just something that's like it's like a program on your computer. Yeah, you're really not thinking about it, but it's running in the background, okay? And so the somatic nervous system is under conscious control, skeletal muscles, and then you hit the autonomic nervous system. And the autonomic is not under conscious control. It runs in the background. And the autonomic nervous system controls things. For instance, insulin being secreted out of glands. You're not hopefully thinking right now, gosh, I'm wondering if my pancreas is secreting enough insulin right now or enough glucagon. You hopefully don't have those thoughts. If you do, give me a call. I've got some people I can recommend you talk to. But no, you're not thinking about it. It's just happening in the background. Under the autonomic nervous system, which is unconscious control, you hit sympathetic and parasympathetic nervous system. Now, sympathetic, I'm sure if you've taken other courses, especially in psych and so forth at Victor Valley College, sympathetic is like if you jump in your car and you want to compare sympathetic to something, it's your gas pedal. You step on your gas pedal and things begin to speed up, accelerate. In fact, another way you may have heard sympathetic described as fight or flight. Your heart rate goes up. The speed of conduction in your heart rate, going all the way from the SA node all the way down to the Purkinje fibers, speeds up conduction. Okay? But also, if you have your sympathetic kick in, you may have ectopic foci. Other pacemakers in the heart become irritable during sympathetic and start to fire. And then on the other side of that, you hit parasympathetic. Now, parasympathetic has been called rest and digest. Okay, parasympathetic is like you. Parasympathetic, if you compare it to something in the car, is like your brakes. Sympathetic, gas pedal. Parasympathetic, brakes. And the main chemical when you think of sympathetic is norepinephrine. Norepinephrine is very similar to its big brother, epinephrine. You take that as a stimulant. Parasympathetic, the main chemical that it secretes, is acetylcholine. Acetylcholine is sometimes called ACH. And when acetylcholine kicks in, your heart rate goes down. The speed of conduction goes down. Throwing ectopic foci, firing, goes down. Okay? And so once again, it's like putting on the brakes. Okay? And you begin, hopefully, to relax with parasympathetic. And these two systems are counterbalancing each other. They are making homeostasis come in. Homeostasis, kind of an internal balance. Okay? You know, you have a stimulant on one hand, you have a relaxant on the other. Now, that has a lot, again, to do with heart rates and heart speeds and speed of conduction and so forth going on. Okay, and ectopic foci firing. You'll see rides in Disneyland, maybe not right now, but rides that say, don't get on this if you've had previous heart attacks and so forth. Well, the reason you want to get on it is because it's going to cause a stimulant to kick in. It's going to be like drinking 5 of those 5-hour energies, and you're going to get ectopic foci starting to fire. You may have us do a little CPR afterwards, right? Catholic, Protestant, no. Cardiopulmonary resuscitation, all right? Because it's a stimulant. Parasympathetic kicks in, you have relaxation. Okay. Now, the other thing I want to mention, and hopefully I mentioned it last time, but if I didn't, I apologize. I mention it now. We're going to have a midterm coming up. Now, we're not going to meet somewhere, and I'm not going to get on a bullhorn or something. Okay, but the midterm is going to be 100 questions. And it's going to be over the chapters and things we've covered thus far. And I'm thinking of it towards the end of April or maybe the beginning of May. We're also going to have a final coming up, and those are going to be 100 questions, and I'll send those out to you. Once again, I want to give you an opportunity. Call me. You don't understand something, call me. Okay, and I'll try to give you an explanation for it. I'll try to help you understand it. You know what? A lot of times by helping you understand it, I help myself understand it. Okay? And so it's by repeating things over and over again. It's that muscle memory. Okay? And by the way, the sympathetic nervous system, when things kick up and your hands are shaking and you kind of are tunnel vision, okay, you have to repeat things over and over again. You have to read things over and over again, and that's going to help you understand it. You have a window break in the middle of the night, you hear a big thump. Okay. We did a couple of weeks ago here. Okay, my wife started talking, I reached over and grabbed my, 40 caliber squirt gun by the side of my bed. You have to kind of concentrate with sympathetic on, a lot of times you hear it under muscle memory. You have to know what you're going to do. Okay, I think he told you one time I was up in Big Bear and, we were at a house or cabin we were renting, didn't know about it. And all of a sudden, real early in the morning, we heard this big thud, like somebody shaking the doors. My wife said, quick, get the gun, get the gun. Well, it's me personally, I never keep around the chamber, just, for an extra safety. Some people say that's dangerous, but I just don't. And so I loaded it. I jacked back the slide and loaded it, but all of a sudden I looked at it and it felt like the slide was stuck, and I noticed a round sticking out the side of the gun. I thought, oh my gosh, what do I do? Well, unless you review what you're going to do, you're not going to know what you do. And I didn't know what I was going to do at the time. So I kind of I thought, well, I'll just point it at the burglar, whoever it is. And, hopefully they don't see a round sticking out the side. Well, did I feel stupid? So somebody had to go over that with me and say, look, this is what you do and this is how you do it. Okay, so it's like developing muscle memory because your sympathetic kicks in. You're not thinking really well. Again, you get that tunnel vision. Okay, so going over things over and over again. Getting up at 3 o'clock in the morning. You're going to take a little trip to the bathroom. Yeah, you can't go to sleep right away. Maybe you can. Get out your book. It's going to kick in a little parasympathetic over and over and over again. And there's another saying, see one, do one, teach one. Okay, and I don't care who you're teaching to. Your 4-year-old. You go, yeah, they haven't taken basic arrhythmia, Bill. That's going to be a little difficult. It doesn't matter. It doesn't matter. You're sitting at a bar eventually in the future. And you're sitting in a bar and the bartender comes along and goes, what do you have? And what is that book you're reading? Okay. You know what? It's good for him to ask questions. I used to, when I went to Azusa Pacific, I picked up a book and, I was doing biology and a lot of other courses, biochemistry, organic chemistry, general chemistry. I was taking all these courses. And my friend worked at a bar. And I thought, this is great. I picked him up. And, of course, I let him drive home. And he said, so what are you doing tomorrow? And I said, well, tomorrow we're going to go over a biology test. And he goes, so what are you going to test on? And I said, well, we're going to test on a little microbiology. He's going to show us some staph and some, things like that under the microscope. And he goes, Bill, what does staph look like? And I said, well, it's not going to help me telling you. If I describe it to you, it's just going to be a waste of your time because you're not in the class and you're not going to understand. And he repeated the question, Bill, what does staph look like? What do rods look like? And you know what? I started to tell him, and you know what I found out real quickly? I don't know it well enough. Because if you can't explain it, you don't know it well enough. Okay, so it's in see one, I saw one, teach one, do one. Okay, and you're going to be seeing a lot of things in your main textbook. Okay, EKG workout by Jane Huff. In fact, there's 600 strips in there. 600. And you're going to be filling them out. What difference does it make? Look, if you don't want to learn something that evening, the answers are all on the back for every strip that's in the book. Go look at it and fill it in. But again, that helps. Okay. Now, so we're going to be having 100 questions. I'm going to tell you kind of what's going to be on it. In fact, you know what? Every quiz that I've given you, you can probably expect to see that both on the midterm and the final. Questions that are similar. If you're having a problem with something, call me. I need somebody to talk to. No, give me a call. I'll go over it with you. Okay, so we're going to be talking about some dysrhythmia. And again, the only reason that I don't like arrhythmia is because it means take the letter A, put it in front of a medical term, it means without. Dys means difficult, labored, abnormal. So dysrhythmia is probably a more correct phrase than arrhythmia, but it doesn't make any difference. They both mean the same thing. Okay? Now, one of the things you need to do when you run an EKG, remember, if you want to get diagnostic, a 12-lead EKG, but if you look at 12 leads, they're usually printed on a single piece of paper. Okay? And in that single piece of paper are short little columns. What columns? Lead 1, lead 2, lead 3. AVR, augmented voltage right arm. AVL, augmented voltage left arm. And AVF, augmented voltage foot, usually the left foot. We put a lead on the right foot to kind of stabilize the tracing. Okay? And then what do you have? You have the chest leads. Leads V1 through V6 are the chest leads. Now, I know I mentioned this before, but just hitting it again. And by the way, I want you to check your computer every couple of days. Look for other lectures. Look for updates. One of the things we talk about in medicine are planes, P-L-A-N-E. Now, not that thing flying up there with wings and a tail, and engines on the back. But a plane is an imaginary flat field, and it divides the body at various angles. Well, one of the planes is called a frontal plane, okay? Also called coronal. So what did we say? We said a plane is an imaginary flat field, and it slices into the body at a particular angle. Well, the limb leads, 1, 2, 3, AVR, AVL, AVF, are on the frontal or coronal plane. Well, let me show you a plane. Let's play like this a plane. And let's play like this very sharp. And notice what I'm doing. I'm holding this vertically. And watch what I'm going to do. I'm going to come in from the side, and this is going to go all the way through me, just like this. And so a frontal or coronal plane, now I could do the same thing with the heart. Let's play like this, your heart, about the size of your fist. In the mediastinal space, that little space between the lungs here. Okay, I keep doing that because I'm looking at myself here. Remember, we're talking about the anatomical plane here a little bit, and the anatomical view is the person standing erect, the palms of the hands facing forward. Okay? So it's not your right or left, but if I'm the patient here, it's my right and my left. So here's your heart in the space between the lungs. Okay, the mediastinal space. Mediastinal just literally means standing in the middle. And here's your first plane here, coming in like this, right? And it's called the frontal or coronal. Well, if this were sharp and I went through the heart, it would cut the heart into front and back sections, into anterior, front, and posterior sections. Well, the first 6 leads of the body, the limb leads, 1, 2, 3, AVR, AVL, AVF, are on the frontal or coronal plane. So here it is. If I mentioned this before, I apologize, but here it is. It's cutting through your heart. And it's, if this were a camera, right, and this were a beating heart somewhere in outer space, and it goes around the heart and it freezes every once in a while and it takes a picture. If this were going in this trajectory, in this orbit, and there was a laser coming out of it, it would be dividing the heart into anterior and posterior sections. This then being the frontal plane. Okay, a vertical plane coming in from the side, dividing the heart into front and back sections. Then we have 6 chest leads, V1 through V6. Now the chest leads are on the horizontal or transverse plane. In fact, look at this. If I take the paper down, I don't have it vertical, I have it horizontal or transverse. Okay? And look how it's cutting my heart or my body into top, superior, and into bottom, okay, inferior sections. So look how I'm going to rotate the camera now. It's coming like this. So I rotated it from here, going around the heart, into here, cutting right through the heart. So we've got good pictures of the heart. And remember, we've got 12 leads, and a lead is nothing more than a camera angle. Okay? But on that 12 lead EKG, you've got one strip on a single piece of paper, one strip with all the other strips that are very short. And the one is lead 2. And lead 2 is a fast way to determine the heart rhythm and the heart rate. Okay? And you can also do a little bit of deeper analysis, but the heart rhythm and rate are on kind of a lead 2 if you want something very fast to kind of tell you what's going on with the heart. So paramedics coming into a house, probably the first thing I'd look at is lead 2. What's going on? Because I want to kind of tag them and bag them. I want to get them very quickly and load them aboard the ambulance and get them out of it. Okay. So the midterm towards the end of April and the final, probably the first week sometime in April, or I'm sorry, in June. Okay. Midterm, end of April, beginning of May. Final in June, towards the last half of the class. Okay. The final, when I give it, will also be about a lot of questions I've talked about. Okay. Now, one of the things I want to mention, okay, is arrhythmia. But again, before that, here you are standing, you're going to run a 12-lead EKG on a patient. A couple things you need to do. You need to calm the patient down. Why? Because they move. It's going to look like you have running EKG on top of an earthquake somewhere. You're going to see little spikes all the way through the strip. And what is that? Somatic tremor. So somatic tremor is what we call an artifact. Doesn't have anything to do with the heart. It has with patient movement. They're scared, they're cold, so give them a warm blanket or something. Okay? Calm them down, tell them what you're going to do. Okay, so that's somatic tremor. Another thing looks like you've run an EKG. Got an EKG here, right? PQRST, you're running it. And it looks like after you run it and after you print it out, the electrocardiogram, remember a gram is a picture of that particular camera angle, and you got 12 of them. A gram looks like somebody came along with their Sharpie and they went over each of the waves. They went over the P wave, they made it thicker. They went over the QRS, they made that thicker. That's called AC artifact, alternating current. So if you got a big machine in the next room that's doing an X-ray or something, and you're doing a EKG in the next, then that may cause interference, alternating current artifact. Once again, it has nothing to do with the heart rhythm or rate. It has a lot to do with what's going on in that room. Maybe a machine isn't properly grounded, or you've got something using a lot of electrical energy in the adjacent room. The other thing that you have that you're going to see is, so AC artifact, somatic tremor, is wandering baseline. Wandering baseline looks like this. Okay? Looks like you're on a roller coaster. You're running the EKG, it's going all over the paper. Wandering baseline could be because the leads are very tight and you're pulling on them. Okay, so that you can't pull on the leads. Okay, got the machine here, you got the patient here, kind of stretching everything out, like an extension cord. That can cause wandering baseline. So you want to try to avoid artifact. The other thing you do when you run an EKG is you calibrate it first. Well, remember, I'll bring this up. On a horizontal aspect, when you're running the EKG, it is a measurement of time. We can take anything, we can measure the QRS, we can measure the PR, we can measure the QT. I don't know what the QT is, but the QT. Okay. So that is a measurement of time. Remember, each little block on the EKG, the smallest one, is 1 millimeter high and 1 millimeter wide. Again, horizontal, a measurement of time. And each little block is what? 0.04 seconds wide. And then we calibrate a vertical. And a vertical aspect is amplitude or voltage. I mean, if your ST segment is below the baseline, or if it's elevated above the baseline. Remember something I told you before, STEMI. ST segment elevation MI. ST segment elevation MI. Well, if it's elevated, I can tell how many millimeters it's elevated. So when you run an EKG, you want to see if it's calibrated first. You want to calibrate it. And one thing you want to calibrate is how fast that paper is coming out of the EKG machine. And we run it at 25 millimeters per second. Okay. Well, that's an interesting statement. If you take 0.04 for each little block, and you multiply that times 25, what do you get? You get 1 second. So there's a knob, there's a switch. You can actually turn on the EKG machine. And you can double the normal run speed. Normal run speed, 25 millimeters per second. Multiply 25 times 0.04, you get 1. 1 what? 1 second. Now, if you got a real slow bradycardia, right? Here's a beat, over here's one, way over here. Well, you don't want to be looking like you're work for Charmin or something. You want to kind of speed that up a little bit so you can double the run speed up to 50 millimeters per second. Let me tell you something. If you do something different on EKG, you put the leads different, you double the run speed to 50 millimeters per second, you need to write that. You need to chart that. There's something in nursing and in medicine we call the golden rule. Okay, the golden rule is if it wasn't charted, it wasn't done. It's real simple. You send something into the lab, it better be charted. You give a medication, it better be charted. Okay. So we chart all that, where we put the leads. We chart when we ran the EKG. Okay. We chart that we calibrated it. All right. Now, the other thing that's real important on that, okay, is height or depth of a wave. And we have something that kind of looks like a little bit of Lincoln top hat. Looks like we're looking at President Lincoln. It kind of looks like this. Now you can see that right here. Okay. And once again, this looks like we're looking at Lincoln with a top hat on. And what this is going to do is this part of your calibration. And what it's adjusting is amplitude or voltage. Let me say it again. Amplitude or voltage. What you want this to do, and this is going to appear somewhere at the end or at the beginning of each lead. What this is going to do is come up 10 little blocks high, 10 little blocks high, go over and drop down. You may not have to count each little block, but you're counting. Remember, each big block is 5 little blocks. Okay, so we're going to have 10 little blocks high coming over and dropping down. We want to make sure that the amplitude or voltage is set correctly. Okay. All right. So you want to calibrate your EKGs. One big important thing, and I don't know how many times this has occurred in the hospital, in a doctor's office, is limb lead reversal. I'll get back to you later on this and tell you a few more things that you can do. But I think before you run the EKG, you want to make sure that you don't have a limb lead reverse. And again, so you don't want to put a right arm and a left arm and this type of thing. Once again, I think I told you, but I can't remember back, is I had a couple of girls in my class one day come in, and she goes, very interesting, because they were in Air Force Reserves, and they said, we had a couple of pilots come in and land the plane. Hopefully they would do that. And they came in with their jumpsuits on, and they had to have, part of a physical done. And they said, oh my gosh, you're going to run an EKG? Do we have to take our jumpsuits off? Oh, no. Oh, no, she didn't do it. Somebody there did it. And they said, we'll just kind of put the leads, wherever we can get to skin, this kind of thing. So they ran the EKG, and then they sent it to the flight surgeon. Well, he looked at them and said, who are these guys? Where are they right now? Well, they left and went over here. He goes, well, tell you what, you ground them right now. They're grounded. Something is really wrong with their heart. Well, what was wrong? They just put the leads wherever they wanted to. You can't do that. If it says right arm, you got to put the RA. You got to put the lead on the right arm. LA. It's about 90 miles an hour. Left arm. Okay. You've got to put them correct. So before you run the EKG, check it. Make sure that all your leads, and every lead is labeled V1, V2, V3, V4, V5, V6, AVF, AVL, AVR, lead 1, 2, 3, every one of those are labeled. Just make sure they're in the right position. Okay, so calibration, making sure you don't, because if you get limb lead reversal, guess what? You can't use that EKG. They'll just rip it up, throw it away. Okay? If you hear my grandfather clock going off in the background, sorry about that. You're going to have to put up with it like I put up with it. All right. Well, one of the things you're going to look at on the EKG is normal sinus rhythm. And we've gone over this before in your class, because if you're going to tell me what's an arrhythmia is, you've got to know what normal is. So what do you do in an NSR? Well, one of the things you do, like you're doing with any other rhythm, is you look at what the rate is. You calculate the rate. Now, in the back of your book, your main textbook, EKG Workout by Jane Huff, is a little card. And I don't care whether you use that card or you use calipers, but you need to determine what the rate is of each of the rhythms. Okay? You also need to determine whether the rhythm is regular or irregular. Now, I don't have to know what it is right away, but I mean, if you got something here and then real close to it, and way over here, another beat, well, obviously the rhythm is irregular. So is the rhythm regular? We do the same thing. What artery is this? Radial. We take a pulse in the hospital, it's usually radial artery. Okay? So when we're feeling it or palpating the radial pulse, we want to know, we want to write not only the rate there, but is it regular or is it irregular? They also want to know the rate. Why? Well, normal sinus rhythm, NSR, or RSR, regular sinus rhythm, should be regular. If it's not, then it's not regular sinus rhythm. There's something else going on. Okay? So we want to determine rhythm, regular or irregular. And you can chart that. Okay? You don't have to put, like some people do, PVCs. You're not going to know if it's premature ventricular contraction by feeling the radial pulse or the carotid or any other pulse. Okay? So you want to know regular or irregular rhythm. You want to know the rate. Okay, again. Now, why is that? Because we know that NSR, normal sinus rhythm, is between what? 60 beats per minute to 100 beats per minute. If it's somewhere between 60 to 100, probably, not 100% of the time, but probably you've got an NSR, a normal sinus rhythm. The other thing to analyze a rhythm strip is you want to look at the P waves. And you want to find out, is there one P prior to every QRS? Because there should be. If it's not, you probably don't have a regular sinus rhythm. Okay, you've got something else going down. So 1P followed by 1 QRS. Okay, but you want to look at the P waves. How did they look? How is their morphology? How is their shape? So you want to look at the size, the shape, and the directions of the P waves. And probably a good lead to do this is lead 2. You also want to examine the PR. Where is that? From the beginning of the P to the beginning of the R. What's the normal PR? 0.12 to 0.20. Okay, 3 little blocks to 5 little blocks. Now, if you've got something greater than 0.20, again, you probably don't have a normal sinus rhythm going on. You've got something else, maybe a block. And then you want to measure the QRS. What is the QRS? From the beginning of the Q or the R. Remember, again, we don't want to see Qs, usually. We see little tiny bitty ones, insignificant Qs. That's okay. But if we see significant Qs, we're probably dealing with an infarct, either a present one or an old one. So we want to measure the QRS. What is a normal QRS? 0.10 or less. What does that mean? Each little block is 0.04. If we take 2 little blocks, right, that's 0.08. And if we take 2.5, you can cut a little block in half, all right? We've got 0.10, 0.10. So 0.10 or less is a normal QRS complex. So you see a big wide QRS? That's not normal, that's abnormal. So when you analyze a rhythm strip, you're going to look at rhythm, regular, irregular. You're going to look at rate. Is it somewhere between 60 to 100? You're going to look at the P waves. You're going to look at their size, their shape, their direction. You're going to look at the PR. Is it there? Is it normal? Okay. You're going to look at the QRS. Is it within normal limits? Okay. Is it narrow? Okay. So you want to have those 5 areas in the background when you examine a rhythm strip. Okay, now you're going to see me looking down a lot because I don't want to leave something out, but here we go. One of the things you're going to look at when you examine, and I'll tell you where I am in the book, I am looking at chapter 6, sinus arrhythmias. Now we're going to get to junctional arrhythmias. We're going to get to ventricular arrhythmias. We're going to eventually make it there. But when you're looking at sinus arrhythmias, you want to find out, is it normal? Well, how's the rhythm? Should be regular. How's the rate? Should be somewhere between 60 to 100. Now remember, I mentioned this before, anything greater than 100 is defined as tachycardia. any rhythm grader. It's something tach. Okay. You want to look at the P waves, the size, the shape, the direction. You want to examine lead 2 for that. If you look at the PR, should be somewhere between 0.12 and 0.20. And again, PR, I just don't want you to go, yeah, 0.12 to 0.20. What is it? What's it represent? Oh, the beginning of the P to the beginning of the QRF. Well, no, that's not what I'm asking you. I want you to know it a little bit deeper now. It represents what? PR. The beginning of atrial depolarization and subsequent contraction to the beginning of ventricular depolarization. The beginning of atrial depolarization and subsequent contraction to the beginning of ventricular depolarization. And you want to look at QRS. What's that represent? Ventricular depolarization from the beginning to the end. QRS should be 0.10 or less. So picking out, and the other thing I told you to do is take your calipers and go at the peak of one P to the peak of the next. Just look, if you pulled them out of here, okay, and these were your calipers and they're pulled apart so long, you go from the peak of one P to the peak of the next, all the P's should march out, okay? Then you measure the peaks of QRSs, okay? All of those should march out. And your P to P interval and your R to R interval should be exactly the same. Why? Because they're all being controlled by what? The sinoatrial node, posterior wall of the right atrium. That is the pacemaker. So if the SA node is calling out the rhythm here, it ought to be the same. It ought to march out. So the atrial rhythm ought to be the same thing as the ventricular rhythm. Shouldn't be any different. It's like you got a drum major in front of a band, or you're marching, okay? And you've got somebody calling out cadence. Right, right, or left, 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 right, left. Okay, you've only got one person. So both all the people in the front and all the people on the back ought to be marching to the same beat. Okay. Atrial rhythm and ventricular rhythm should space out, should be the same. Now another thing here, and again, I'll tell you what page I'm on so you can kind of review, and I'm on page 45. And I'm looking at sinus tachycardia. Well, what's an easier way to kind of learn that? Ready? NSR rate is faster than 100. Why? Because sinus rhythm is 60 to 100. Tachycardia, tachy, fast, cardia, heart. Tachycardia is a rate greater than 100. Okay. So you're looking at sinus tach, and it's a rate greater than 100. The P waves are normal in size, shape, and direction. The rhythm is normal. The PR is normal. QRS normal. The main thing I want to hear from you is NSR greater than 100, because that is a sinus tach. Okay. Why would you get one? Well, you're exercising. You're watching the news. Let me tell you something on the side here a little bit. You want to lower your heart rates down a little bit. You want to kind of feeling relaxed. You're really uptight, and I understand. I mean, you watched my first video. That's an uptight person a little bit. The best way to do that is quit watching the news. You want to get regular updates, go to the CDC, the Center for Disease Control from Atlanta, Georgia. Okay, and by the way, I'm going to try to post something for you. It is a conversation with a New York doctor. And I'll tell you what it did for me. It calmed me down. Why? Because I was thinking of all the bad things that could really happen. You know, we're going to go to that movie Outbreak. And the entire earth is going to be wiped out. That's not true. There are things that you can do, and they're basic things that have been taught to us forever. Hand washing. And by the way, ladies, if you're listening to this, most guys don't know how to wash their hands. And I'll tell you what, I consider myself an expert in hand washing. I consider myself OCD in hand washing. You go, well, how do you know the rest of us, a lot of us are not, especially guys, are not doing hand washing correctly? In the Allied Health Department, the old building, they have one toilet. One. And I usually reserve it, between 2 and 3. And I'm uptight when somebody comes in. He goes, how do you know they came in? It's obvious. Door's banging. And sometimes, and I don't know what's wrong with people, but they come up to the door and they go like this. The inner sanctum, the one toilet. And guess what? It doesn't open. Now, what would your brain tell you? There's probably somebody in there. But then people shake it harder. And then some people are brain damaged. They look under the stall. Is there somebody in there holding the door so I'm looking at? No. And if they look under, you know what I do? I lift my feet up. Because I'm embarrassed to be on the toilet. I just don't want somebody to see me in there. Because I think they may start a conversation. Mr. White, is that you? No. And I've even answered my phone. They go, you're not busy right now. No, I'm not busy. Listen, if you ever call me and you hear an echo in the background, water running, hang up and call later. I'm not by Niagara Falls. I'm probably in the restroom somewhere. Okay, and so I listen to these people wash their hands. Why? Because they walk up to their wall right beside the toilet, and I can see their feet. What are they doing? Well, it's not the Wailing Wall. They've got a urinal, kind of like a bathtub plugged to the wall, and they're using the urinal. Now, I don't want to go into this too deeply, but what are they touching? Thank you. And then what do they touch? They reach up and they touch the handle, the same thing that everybody else touched. And then what do? They walk over to the sink, and most people don't even go to the sink. They just walk out and see you in the hallway. Hi, how you been? Okay, that is transferring organisms, microorganisms. You can't see them unless you have a microscope. And viruses you can't see unless you have an electron microscope. Those are really small. HIV, it's a virus. So you want to wash your hands and forget this happy birthday stuff. If you sing happy birthday once or twice, you're done. Not me. What I do? I go over and get turn on the faucet. Well, how do you turn it on? Well, I like those things that automatically turn on. Sometimes they scare you. I was in a restroom at the hospital, and I walked up to the sink, and all of a sudden I heard this shh. I go, what is that? And then I turn, and I go, whoa, there's a paper towel. Everything's automatic. If you can, get a paper towel and turn on the faucet. Okay. If you can. Okay, wipe your hands with a clean paper towel. Don't use the same one you turned on a faucet with. Hello. But look, you got fingers, right? You got a front and a back of the finger. You got sides. Here's me. Get the finger really good, No, I don't have scrub brushes, nails. Get those puppies, okay? And you know what most of my books say? Look, you got contaminated, you touched blood or pee-pee or whatever, okay? Sorry, you guys are medical. Urine, right? Poo-poo, feces, yeah. All right, wash your hands for about 2 minutes. And I was in Vegas with a friend of mine. I was going like this, going like this. Yeah, yeah, yeah. And my friend just stood there and his mouth was open. He just watched me do this. And he finally turned to me and he goes, Bill, could you do that one more time? He goes, I've never seen anybody wash their hands like this. Well, when it comes to me, I'm a little OCD. I make sure, especially with this stuff going on. The best way to get rid of microorganisms on your hands is to use soap and use water. Not this antibacterial stuff. In fact, antibacterial soap is probably the worst stuff that you can use. Go, why? It gets rid of bacteria. No, it feeds your microorganisms a little bit of the stuff that we're trying to get rid of the organism with. And it builds up what? Resistance. Just like you take an antibiotic, and we told you to take it for 7 to 10 days and have it on your shelf still. Why? You felt better. No, we want to give you the antibiotic for 7 to 10 days to get rid of it. If you don't take it for the full length of time, guess what? You got little guys with t-shirts on running around your blood saying, I love amoxicillin. Okay. I love Cipro. Ain't so bad, ain't so bad. Yeah, and they're running around because they're still alive. We want to kill them. Okay. First 5 layers of your skin are most of the transient microorganisms. You want to try to get rid of a lot of these guys. So hand washing is what I call it. Okay? And if you touch something that's dirty like the floor, you want to wash your hands before you go do something else. I'm going to tell you where I was. I was at a doctor's office. And the guy came to the waiting room. And he said this, "Be that." And I looked up, because it's, "Be that." Is he calling me? Are you looking for Bill White? Yes, Bill White. Hello. I go, follow me, follow me. And so I walked back with him. And every desk where he wanted me to sit had open alcohol swabs on it, had the sharps box and needles on the floor. My first medical term reaction was, WTH, the heck is going on? And then, you know what he did? He moved the sharps box, and he picked up stuff off the floor, and he goes, Bill, kind of dirty today. You Bill White, right? Am I Bill White? Yes, I got a letter yesterday. Let me check it out real quick before I answer you. And then he went over to my medication, to an IV. He was going to start, and he started touching the IV, and I said, whoa, hello, wait a minute. Are you going to wash your hands before you touch this? Wash my hand! Wash my hand! You're right, Bill White. You're right. Wash my hand. I'll let the nurse do it. So here comes the nurse. No gloves, no nothing. Almost the same thing that he did. Hello. And then when I started to walk out, I had a IV, tubing and stuff still in my, needle still in my hand. He pointed to it and he goes, I said, the IV? Yeah, you need to take it out. You want me to take it out? Okay. So he goes, you know what? The nurse will do it. Come to the waiting room and do it. Here comes the nurse, sits down on the floor, takes a bunch of, 2x2s, little dressings, lays them out on his pants, no gloves, picks up stuff off the floor, the 2x2s, and what's that do? It transfers the germs right from the floor right to the hand. So some of this that I'm going to send you, this tape by the doctor, talks about hand washing, okay? And doing it regular. Or if you don't have some soap and water, right, use Perel or whatever it is. Try to get some of that stuff, okay, if you can, because when you're out, you usually don't carry a sink around with you. Okay. All right, so sinus tachycardia. What's the etiology? E-T-I-O-L-O-G-Y. What's the etiology? The cause, usually the cause of a disease. So the etiology for sinus tach, and sinus tach is normal. You go work out, get some sinus tach. You review your checkbook, a little sinus tach, right? The rhythm is regular. The rate is over 100, greater than 100. P waves, normal in size, shape, and direction. PR, normal, 0.12 to 0.20. QRS, normal, 0.10 or less. Okay, now I'm looking at sinus tach right at the bottom here, page 45. Let me tell you what I see. I'm going to go look for an R wave on a heavy black line. I'm not going to count that line. That's where I'm going to start. Now, you know what I'm doing? I'm looking right at figure 6.3 on page 45 at the bottom. And so I find the R wave, the one all the way to the left, okay, is on a heavy black line. And then I go 350, 350, 100, 75. Well, let me try that again. 300, 150, 100. 300, 150, 100. That looks a little faster than 100. So guess what? It's 125. Now, if you don't want to do that, take the number of little blocks between two R's, right? Number of little blocks, multiply that times 0.04. Okay. Let's see what I get here. I haven't done this way that I'm telling you right now, but multiply that times 0.04 and you're probably going to get somewhere around 125. Okay. Now, the causes, drug withdrawal, intake of amphetamines, stimulants, caffeine, nicotine, cocaine, Coca-Cola. I don't know how come they all start with a C. Physical exertion can cause sinus attack. Is sinus attack a big deal? No. Not unless it's so fast it's going to cause you to have a syncopal episode. Syncope. S-Y-N-C-O-P-E. Fainting. Pass out. Why? Because the heart doesn't have enough time to relax and fill with blood before it goes into another contraction. And you start getting contractions that are way up there, right? Then what's going to happen is you have cut down on what? Preload in diastolic volume. Okay? And you're not going to get enough blood and oxygen, enough perfusion, blood flow to the brain. Okay, I'm looking at sinus braid over on page 46. You're hypoglycemic. You have sleep apnea. You have hypoxia. Okay? You have high potassium. Those all can cause bradycardia. Now what are we at? We're in an NSR. Make sure you memorize these little fast ways. NSR, a rate less than 60. Okay. All right, so hypoglycemia, low blood sugar, high serum potassium, sleep apnea, those all can cause very slow heart rates. Okay. What's the rhythm? Regular. What's the rate? 40 to 60. Rate less than 60, 40 to 60. P waves, normal, size, shape, and direction. The PR, normal, 0.12 to 0.20. The QRS, normal, 0.10 or less. That's how you can identify. Listen, when I give you all these things about the cause, don't memorize them all. Memorize a couple of them. There we go. Okay. If somebody says, describe sinus bradycardia, we just did. Make it simple. Don't pick up all of these paragraphs and think I have to mention it to the person who's interviewing me. All right, sinus arrhythmia. Well, where do we go on sinus arrhythmia? Well, the rhythm is, if it's arrhythmic, the rhythm is irregular. The rate is somewhere between 60 to 100. The P waves are normal in size, shape, and direction, usually positive and lead to. The PR is normal and the QRS is normal. Now, I'm going to make sinus arrhythmia easier for you. So when you go P to P and R to R, they don't space out. Okay, the P waves don't march out and the R waves don't march out. Okay. So if we go down to what could cause it, I'll give you a real simple one and one only. Breathing. You breathe in, inspiration. You breathe out, expiration. What's your normal respiratory rate? Somewhere between 14 to 20. I know some books will say 12. Close enough for jazz, all right? So we give you sinus arrhythmia. The P's don't space out. The R's don't space out. So the rhythm isn't regular. Okay, but it's very slight, irregular. Okay, so breathing in, inspiration. Okay. When you breathe in, your heart rate speeds up. Okay. When you breathe out, your heart rate slows down. So that usually, a lot of times, just the way the person's breathing, calm them down, tell you a picture of what you're going to do, will cause a little bit of sinus arrhythmia. Is it a big deal? No. No, not really. All right. One more thing I'm going to talk about today, and I was going to make this tape shorter, and I promise I will make the other ones, is sinus arrest, sinus exit block. Sinus arrest, sinus exit block. Let me tell you where I am. I'm over on page 48 and 49 of your main textbook. The rhythm, usually regular, although there's a sudden pause in the basic rhythm. Okay. The rate. The rate is usually that of the underlying rhythm. The P waves are absent during the pause. The PR, normal, 0.12 to 0.20. The QRS, normal. Now, both sinus arrest and sinus block, what I'm talking about right now, if I didn't say it, sinus arrest, sinus block, are no big deal. They really are not. Okay? And in sinus arrest, sinus block, sinus arrest, sinus exit block, we use the big term to kind of tell about both, and that's sinus pause. So if somebody says sinus pause, they're either talking about sinus arrest or sinus block. Now, I have mentioned this to you guys before, and I'll tell you where I'm looking right now. I'm looking over at page 49. And what they tell you to do when you're looking at a rhythm strip, see if all the peaks of the QRSs march out, the peaks of all the P waves mark out. But then all of a sudden at the top of page 49, you have a pause. And you're not sure, is that pause sinus arrest or sinus exit block? Well, I'll tell you what, as far as I'm concerned, you could say sinus pause. But if you really want to know, you would dive into this thing a little bit more. Again, strip at the top of page 49, strip 6, 7. Notice everything's regular, and all of a sudden you have this line. And now, what you do is you go up from your last QRS, the peak of the QRS, peak of the R wave, and you move your calipers over again to the right, and then again to the right, till the rhythm picks back up again. And you know, look at what it says at top page 49. The R to R regularity, the rhythm resumes on time after the pause. Let me say it again. The rhythm resumes on time after the pause. Well, if it resumes on time, that's a sinus exit block. Okay? So you're like this with your caliper, right? And then over here is a pause. So you're going R to R, R to R, R to R. You hit the pause, right? Move your calipers over a little bit, go right across the pause. If the rhythm picks up back on time, and what I say, if it picks back up again on time, okay, it is a sinus exit block. Okay? And when it picks it up again on time, it should be within 2 little blocks of where it was before, within 2. And that is a sinus exit block. If it doesn't pick up again on time, if it's a sinus arrest and doesn't pick up again on time, all right, the rhythm is still regular, except for the pause. The rate is that of the underlying rhythm. The sinus P waves with the basic rhythm are absent during the pause. The PR, 0.12 to 0.20. The QRS, 0.10 or less. Okay, so if the rhythm doesn't pick up again on time, it's a sinus arrest. If it does, it's a sinus pause. But who cares? You go, why do you say that? Because sinus pause and sinus arrest are both treated the same way, and it's usually no big deal. Okay? If I were you, I'd just say sinus pause. All right, you know what? We're going to pause here. And you're going to keep reading all the way from where we were. Okay. And now I'm on page 50. And we're going to start looking at these strips and filling out the rhythm, the rate, the P waves, the PR, the rhythm interpretation. Okay. You guys, I hope you have a good evening. I'm going to probably put in a couple of more videos this week. If you have a problem, you give me a call, 760-963-0943. God bless. Have a nice evening. Be safe. Okay, and if you see that other video posted by the doctor, okay, I want you to listen to it. Because again, it relaxed me. Mrs. White, can you come in here for a second? This isn't part of the video. I'm just bringing her forth. Peggy, can you come in here for a second? I need your help. Okay, well, I'm waiting for my wife here. We're going to hit the pause button here really quick. They're not going to just pause it or do whatever you need to do. Just stop it.